Hello, everyone. Welcome and thank you for joining us today. My name is Lisbeth Gall. I'm the Population Health Training Manager at the National Center for Farmworker Health. We are very pleased to host a two-part training series focused on improving the sexual health of agricultural workers. These events have been organized in collaboration with the New York City STI HIV Prevention Training Center team. Thanks for joining us today in this first training, which will provide an overview of sexually transmitted infections in the United States and among agricultural workers. Next slide, please. For those who may not be familiar with NCFH, we are a private nonprofit organization located outside of Austin in Buda, Texas, and our mission is to improve the health of farm worker families. And we do that by providing programs, trainings, and technical assistance and resources, and we are proud of being able to serve 174 migrant and community health centers in our network who provide primary care services to agricultural worker families. Next slide, please. Today's learning objectives include to increase awareness about the rising rates of STIs in the United States, to delineate factors contributing to STIs and HIV among agricultural workers, and to describe challenges in providing information and services to agricultural workers. Next slide, please. I am now pleased to introduce our guest speakers, Dr. Amasti and Dr. Kohol, who will introduce themselves, and they will also speak a little bit about the STI and HIV Prevention Training Center. So the space is all yours. Thank you for being here today.
Okay, can you see my slides?
Yes.
Terrific. So I wanted to thank Lisbeth and Vanessa and Lisa for their kind invitation to talk with you all today. And I want to thank you all for spending time with us this afternoon. Now, if I can just advance my slides, we'll be in good shape.
Dr. Cole, if you can't see the menu to advance slides, if you hit the arrow key on your keyboard, that should also work.
Well, I'm hitting all the arrows. Let's see here.
Would you like me to share the slides, or are you okay with that?
Yeah, why don't you try?
Okay.
Or unless I can do it. You're doing it from your end?
Yeah. I'm doing it now. So what I'll do is I go all the way up. And can you see that?
Yes.
Okay.
All right. Sorry for the technical difficulties. Dr. Amnesty and I have nothing to disclose except, like all of you, we are very passionate about improving the health of priority populations. Next slide. So in terms of my background, I am a professor of public health and pediatrics. My focus is on adolescents and young adults. I run a number of programs in the hospital for young people living with HIV and who have sexually transmitted infections. And we do a number of innovative outreach programs in the community to identify folks who are at risk for STIs and HIV, provide screening and linkages to care at our hospital, And we'll talk more about that in the October webinar. In New York City, we've been seeing a number of folks coming into the city from other countries, many of them immigrants. So our clinics have seen an uptick in individuals coming from Mexico, Central America, South America, and so on. And some of these individuals have sexually transmitted infections and HIV. And we'll highlight a few of those cases today. I also started a new clinic recently that provides comprehensive medical and mental health services for folks coming home from jail and prison. And I also teach at the School of Public Health at Columbia, as well as in the medical school. Next slide.
Oops.
Dr. Amnesty.
So should I do that?
Yes.
Okay. So thank you all for being here, and thank you to everybody, Elizabeth, Vanessa, Gowrie, everybody who helped with the presentation and with putting this together. I am an associate professor also at Columbia, been working with Dr. Coho on and off for the past, I think, 20 years. I am a family medicine physician, and I also do work with adolescents and young men. And we have a clinic that's called Young Men's, and ours, focuses on sexual and reproductive health, because we see a lot of patients with uninsured. We end up seeing a lot of immigrants, undocumented. So as Al says, Dr. Coho, we have been seeing a lot of the numbers increase. I also work with Dr. Coho on his new, initiative with Center for Hope and Resiliency, and I teach public health students, medical students, and also residents in family medicine at Columbia.
Next slide. So again, we just also wanted to thank, in addition to Elizabeth and Vanessa and Lisa, Gowrie, Jessica, Cindy, for their help in putting this presentation together. So they all work for our New York City STI HIV Prevention Training Center, and I'm the director of that center. Next slide. So this center provides consultation and training for providers. So if you all want additional information about some of the STIs we talked about, in addition to the training that we're going to do, you can log on to our website and get more information. And we'll put that URL up later on. So we have a lot of work to do with respect to STIs. We can prevent STIs and HIV through getting people in, helping them to utilize condoms and pre and post-exposure prophylaxis and getting them on vaccines. And we'll talk more about that perhaps in the second part of the webinar. We can do a better job with screening and identifying folks with STIs and HIV. And then once we identify them, we can treat and help them manage their infections. And in doing so, we can help them live longer and healthier lives. Next slide. So that's the vision, that's the potential, but the reality is that many people lack information about these basic infections. If they have awareness, they may not know where to go to get care. They may not have insurance or money to get the services that they need, or they may be embarrassed. They may feel stigmatized. They may be afraid of getting care. They may have had negative experiences with healthcare providers. There may be competing priorities. They may not have time to take time off from work to get care, or they may have other obligations that get in the way, caring for their children, caring for their parents. So there's a lot of barriers, a lot of challenges that people in general have to deal with. And then we'll get into the specific challenges for the agricultural workers throughout this presentation and the next one. Next slide.
Yeah, you got it?
Yep.
Okay. There you go. Hold on, I lost it for a second. Hey, I'm screen sharing, right?
Yes.
I can't see what I'm sharing. Okay. Okay. There you go. Sorry about that.
So we really think it's important that you all, community health workers, play an important role in closing these gaps. You all know this population extremely well. They trust you. You speak the language, not just Spanish, but also the language that they need to know in terms of understanding and taking care of themselves and their families. So we really think you play a critical role, and we're glad to work with you in this regard. Next slide. So to better inform our training, we want to hear from you. Next slide. We had sent out a link to a survey that asks some in-depth questions about the kind of issues that you're dealing with, the kind of information you need to do a better job. So if you filled out the survey a day or so ago, that's terrific. If you haven't, take out your cameras, take out your smartphones, and take a look at these QR codes. One of them is in English, the other is in Spanish. And if you point your cameras at these QR codes, it'll provide a link to a survey that we would like you to fill out to help us get more information about how to help you help these populations better. So we don't want you to take the time to do it now. You can do it at the end of the presentation or later on today. But that information that you provide will help guide us in the next presentation. Next slide. So with that as a introduction, let's get into the topic. Next slide. So we want to start out with a survey that was done by the National Center for Farm Workers Health a couple of years ago. They surveyed about 55 individuals working with this population, serving farm workers in about 21 states. And what they found out was that folks taking care of this population wanted to know more about the basics about sexually transmitted infections. They wanted to know how to better talk about sexually transmitted infections with farm workers. And they wanted to know strategies for addressing stigma, among other issues. So with that in mind, we created 2 webinar formats. Today, we will talk about STIs in general, and we'll begin the discussion about barriers and challenges to prevention, screening, and treatment. And in the second webinar in October, we'll talk about innovative strategies to reach farm workers and provide them with services. And we'll also talk about any of the issues we didn't get a chance to get to today. Next slide. So we're going to start off by talking about the impact of sexually transmitted infections on the health of individuals. For some of you, this will be a review. You've kind of heard about this in the past, but we think a review is always helpful. For some of you, this may be an introduction. You may not have had this topic discussed before. So we really think it's important to get everybody on the same page. So we're doing this basic introduction to start off with. Next slide. So we're going to give you a brief overview of STIs in the United States. We'll talk about signs and symptoms of some of the more common STIs. And the ones that we don't get to today, if you want to, we'll talk about the others next time. We'll talk about the complications of STIs if they're not treated and treated promptly and efficiently. And we'll talk about the link between STIs and HIV. Next slide. So this slide basically says that STIs are common and they are increasing, particularly gonorrhea and syphilis. We're seeing more cases of this in the United States. And this is actually an undercount because a lot of people aren't coming in for screening and treatment, as we'll talk about a little bit later. So there are tremendous costs to these infections. It's estimated that the price tag to American taxpayers is about $16 billion, and that's billion with a B, dollars each year that's associated with the treatment of these infections and their complications. Next slide. So anyone who's having unprotected sex with someone who's infected is at risk, but we really want to pay special attention to young people. Young people represent about 1/4 of the population, but they are disproportionately impacted by STIs. About over 50% of the 20 million new cases of STIs each year are seen among young people 15 to 24. But it's not just young people we need to be concerned about. Next slide. We need to be concerned about older people as well. Older people are having sex for a variety of reasons. Viagra and Cialis is on the market. There's dating apps for older people, people who have been widowed or who have been divorced are now getting back out into the game, so to speak. So we need to be concerned about STIs across the age spectrum. Next slide. So, as I said before, anyone who's having condomless sex can be at risk for an STI, but we're seeing a heightened need to pay special attention to people of color. We're talking about Native Americans, African Americans, Hispanic Americans need particularly an increase in services and attention to help level the playing field. Next slide. So we know that statistics are important, but we really want to take time talking about putting a face on the statistics. So we're going to be using a case-based approach. These are actual cases that we've seen in our clinic. We've changed the names of them, and the pictures are not of them in particular, but we think their stories are particularly important. So we're going to do a general overview about STIs with these cases, and Dr. Amnesty in her presentation is going to make it much more relevant to your particular population. Next slide. So our first case is Ramon. Ramon is a 24-year-old Latinx cisgender person with a penis. He has oral and vaginal sex with people with uteruses. He reports having burning when he urinates, and he's noticed yellow, thick fluid at the tip of his penis, which stains his underwear. He has not been using condoms with his current partner, who he's been with for over a month, because she's on the pill, and he thinks she's clean. And in their minds, birth control contraception is much more important or much more of a concern than infection control. So he comes in, he gets checked, his lab tests show negative for HIV and syphilis, but he has been exposed to both chlamydia and gonorrhea, which are STIs, sexually transmitted infections. The next case is Victoria. Victoria is a 19-year-old Latinx cisgender person with a uterus. She is Ramon's partner. She's been having discomfort during sex and has noted a vaginal discharge which stains her panty liners. And notably, she's had a fishy odor through her vaginal discharge, which is unusual. She comes in for testing also because Ramon said, hey, you got to go get checked out. And her tests also show negative for HIV and syphilis. But not surprisingly, she has chlamydia and gonorrhea. But an additional test shows that she also has another infection called trichomonas. Next slide. So let's talk about the common signs and symptoms of these STIs, how we screen for them, how we treat them, and what happens if we don't get the treatment. Next slide. So common symptoms in people with penises are discharge from the penis, burning on urination. They may have discomfort when they ejaculate. For people with uteruses, they may have a vaginal discharge. It may be uncomfortable when they have sex. Next slide. They may have frequency of urination. They may have burning on urination. Sometimes they think this might be a bladder infection or a urinary tract infection. But STIs can also cause similar symptoms to a bladder infection, but they're treated differently. Next slide. So for folks who are having oral sex, if they have condomless sex with someone who has an infection, they may develop signs and symptoms of a sore throat. And a lot of times people come in and they get a test for strep or something else, and that test is negative, and they think, okay, well, I'm fine. No, it really could be a STI. So doctors and nurse practitioners and PAs need to ask the right questions and do the appropriate tests. Next slide. People may also have rectal discomfort if they're having unprotected anal intercourse. That could be discharge from the rectum, mucus, bleeding. They can have itching in the anus. they can have discomfort when they're having a bowel movement. All that could be as a result of having an infection like chlamydia or gonorrhea. Next slide. So our first question for you all is, we talked about these common signs and symptoms: burning on urination, frequent urination, discharge, pain. So what is the most common sign or symptom of chlamydia or gonorrhea? One of these, all of these, or none of the above? So take a second, and this is a safe place. You are allowed to give us your opinions, and we'll see which ones you think is most common. So Vanessa, am I supposed to be seeing responses now, or?
Yeah, I don't see the responses, so maybe Vanessa, you see them?
Okay,
Oh, here it is. Okay.
great. So a bunch of people say burning on urination, that is common. Frequent urination, yes, that's common. Discharge, pain, all that's common. And a bunch of you all said none of the above, which actually is the correct answer. Next slide. The most common sign or symptom of having an STI like chlamydia or gonorrhea is no symptoms at all, which is really kind of frightening, because you can have a very serious infection in your body and feel perfectly fine, perfectly normal. Sometimes, though, you may have very mild symptoms. Dr. Amnesty and I have had men come into our clinics with saying, I had a little tickling at the tip of my penis, but it went away, so I'm good, right, Doc? No, it could be an infection, and that's why we need to do these tests. Next slide. So speaking of tests, we've come a long way in terms of testing. 20, 30 years ago, people with uteruses had to have pelvic exams, which are uncomfortable, to get swabs taken to send to the lab for the test. People with penises, we had to put a probe into the penis, which was very uncomfortable. And a lot of times guys would, not want to come in because of their concern about how uncomfortable the tests are. Now the technology has evolved, so we can detect very small fragments of germs in the urine. So people, all they have to do is give us a urine test, and we can find the infection. But we also are mindful of the fact that infections could be present in other parts of the body, like the throat, like the rectum. So one of the things that we are doing now is allowing patients to take swabs of their rectum or of their throat and give it to us, and we take it to the lab. And that's really important, because we can find infections that we might have missed if we just did a urine test. And also, patients now have some control over the testing process. They're less embarrassed about coming in for testing. So this is called 3-site testing or extra genital testing. So we really think that's an important measure to enhance screening and treatment for STIs. Next slide. So we talked about chlamydia and gonorrhea a lot. We have good tests for that in both people with penises and people with uteruses. The third infection that was in this couple was something called trichomonas. We have a really good test for that in people with uteruses, but we don't have a good test yet for people with penises. So it was really good that Ramon talked to his partner, got her to come in to get treatment. He was able to get treatment also because she was found to have the infection. If that was not done, the infection could have gone back and forth between the two of them and could have caused problems. Next slide. So treatment. Treatment for chlamydia and trichomonas is pretty simple. It's antibiotics that folks take for about a week, and that cures the infection. They never have to get it again unless they re-engage in condom-less sex with someone who's infected. Treatment for gonorrhea is an injection. One injection usually cures the infection. Next slide. problem becomes, what if they had not been screened? What if they had not come in for treatment? What could be the consequences? Next slide. And there's serious issues that can arise. So for people with uteruses, this is a diagram of their internal anatomy. And I'm sorry, I don't have a pointer to show things piece by piece. But, you know, at the bottom of the diagram is the vagina. Then it goes into the uterus. And then on either side are the fallopian tubes. And hanging down from the fallopian tubes are the ovaries. Okay, so that's normally what we see internally. Next slide. When someone has an infection with chlamydia, gonorrhea, and or trichomonas, the fallopian tubes, the kind of tube, Sylvia, you want to show those on the sides, which are normally very slender, very thin. They're like strands of spaghetti. They become swollen, red, inflamed. They blow up to the size of sausages. And not only are they red, swollen, angry, and inflamed, inside the fallopian tubes, there's a lot of scar tissue that develops. And that can create a number of problems, as we'll talk about in a second. Next slide. So on the left side of the screen is a picture of the normal anatomy. So what happens is an egg gets released from the ovary. It travels into the fallopian tube. It meets up with a sperm. That egg becomes fertilized. And that fertilized egg travels back into the uterus. The uterus is special. It can grow. It can expand just like a balloon. And then if the couple chooses, 9 months later, they will have a healthy child. On the right side is what happens if a woman gets infected with chlamydia, gonorrhea, or trichomonas. The egg gets released, it meets up with sperm in the fallopian tube, but because of the scarring, because of the damage that we talked about before, it gets stuck in that fallopian tube. It can't travel down to the uterus. The fallopian tube, we said, is very thin, it's very slender, it's like a strand of spaghetti. It's not meant to grow and expand and accommodate a 3, 6, 9 month fetus. What happens then is it pops, it ruptures, it breaks. So blood and pus can leak out into the woman's belly. That is a surgical emergency. It can cause a number of complications, including death. So this is a serious complication which could be prevented by using condoms. It could be identified and treated by people coming in and getting screened and getting appropriate antibiotics. If that doesn't happen, something serious can occur. Next slide. This is internal anatomy for a male. We see in the middle of the screen the bladder up at the top. The bladder receives urine from the kidneys, it stores it, and then periodically gets released through the penis during urination. On either side of the penis are the testicles. The testicles make and store sperm. They get released and travel through a tube called the vas deferens, and again gets released through the penis during ejaculation. Next slide. So on the left side of this diagram, you see a normal testicle. It's round, and then on top of it is something called the epididymis, and next to the epididymis is the tube that takes sperm out into the urethra and into the penis. If that individual gets infected with chlamydia or gonorrhea, you can see now that that epididymis gets swollen, the vas deferens gets swollen. It can also have scar tissue inside, just like in the fallopian tubes of the female. So sperm can get stuck there and not travel out. So the common expression that we hear from guys is that they're shooting blanks. Fluid comes out, and that fluid is prostatic fluid, but it doesn't contain sperm because the sperm is trapped. Next slide. So the major result of these kinds of infections could be infertility. So you could have a couple that's in their 20s or 30s or whatever. They're trying to have a child, but they can't because of an infection that may have occurred when they were teenagers or young adults. Next slide. So let's turn our attention to another infection. This is Jason. He's a 30-year-old Latinx cisgender person with a penis. He is bisexual. He has sex with both men and women. A month ago, he met another guy via a hookup app, was under the influence of a drug called crystal meth, had condomless sex. A couple weeks later, he developed a rash, went to the clinic for a checkup. And this time, the chlamydia, gonorrhea, and HIV tests were negative, but he had another blood test done for syphilis, and that showed that he was exposed to this germ. Next slide. So again, we want to talk about common signs and symptoms, screening, treatment, and complications of syphilis. Next slide. So the first sign of syphilis is a sore. It looks like a cigarette burn on the penis or the vagina or the tongue, whatever body part was used during sex. And as ugly and as uncomfortable as it looks, it actually causes no pain. So people will feel okay, except when they look down and they see this sore. Left to itself, this sore will go away in a couple of weeks. And a person may think, hey, I don't know what that was, but I'm glad it's gone. I'm good to go. No, that's not the case. A few weeks later, they may develop a rash. The rash could be on the palms of their hands or the soles of the feet. It may be all over the body, particularly the arms and legs, the chest, the back. And that rash will go away after a few weeks. And again, they may not know what it is, but they're just glad it's gone. But the infection is still inside, causing damage. Next slide. So let's do the same exercise. What's the most common sign of syphilis? Pain, rash, sore, fever, all of the above, or none of the above? I want to thank you all for participating. This is really helpful. All right, so some people say rash, some people say sore, some people say all of the above, but you all are so smart. Most of you say none of the above, and that's the correct answer. Next slide. The most common sign, symptom of syphilis is no symptom at all. So a person can have this infection in their body and not know about it, which is why it's so important that people come in and get tested. And the test is with a blood test, okay? So in contrast to chlamydia and gonorrhea, where we use urine tests, or we do swabs of the rectum or the mouth or the vagina, with syphilis, we have to do a blood test. So what happens if Jason doesn't get treatment? Next slide. So left untreated, syphilis can cause major damage to all of the internal organs of your body, particularly your eyes, your brain, your heart, your kidneys, and your liver. So if you don't get the right treatment, this germ can damage all of these organs. Next slide. And the most important complication is if you don't get this treated, it can kill you. Next slide. Treatment is actually pretty simple. It's just a shot of penicillin. Usually for most people, it's one shot. If we are not sure how long someone has had the infection, we may have to give them 3 shots. But it can be treated, it can be cured. These major complications that we talked about can be prevented if someone comes in and gets care. Next slide. So there's another problem we need to talk about. Next slide. So women who get infected with syphilis, if they don't get treated and if they get pregnant, the germ can be passed on to the developing fetus. What we see in this slide is a graph of increased cases of syphilis among people with uteruses and also a stepwise increase in cases of congenital syphilis, syphilis that has been transferred to the developing fetus. Next slide. Complications of syphilis in fetuses. First of all, it can cause stillbirth. The baby cannot be born alive. If the baby is born alive, it could have significant damage to the brain. It can cause deafness. It can cause deformities of the bone and also of the face. So congenital syphilis is a serious health problem which can be prevented, but we're seeing more and more cases because women don't know they have it and they're not getting prenatal care. So one of the key messages is if someone is pregnant and they want to continue the pregnancy, let's go get checked out, make sure that you're healthy, make sure that the baby's healthy. Let's do the appropriate tests so that there's something there, we can treat it and prevent these serious complications from happening. Next slide. So let's end by talking about sexually transmitted infections and HIV. Next slide. So this is a case of Mercedes, who's a 75-year-old cisgender person with a uterus. She's a grandmother. She was brought to the emergency room by her grandson because the family was concerned that she had been losing weight and she'd been noticing white patches in her mouth and really couldn't swallow or eat very well. Her husband died a few years ago because of what she was told was cancer, and I put that in quotes. This was an individual who traveled back and forth to different states for work, and she has never had sex with anyone else other than her husband. Next slide. So when she came in for testing, her chlamydia, gonorrhea, and trichomonas tests were negative, but her tests for syphilis and HIV were positive. The white patches in her mouth were a fungal infection, which is a sign of advanced AIDS. Next slide. So as we know, there's over 1.2 million people in the United States that are living with HIV. Next slide. And risk and the number of new cases are not distributed evenly. You see here some states that are lit up in red. We call those the hot spots. Those are states like California, Texas, Florida, New York, many of the states where farm workers live and work. Those are the states with the highest number of new cases of HIV. Next slide. And as I said before with STIs, we also see the same situation with HIV. This is actually an undercount because a lot of people are not getting tested for HIV, so they don't know their status. So they're not getting the help that they need, and they may be transmitting the infection to other people. So in these states with the highest number of new cases of HIV, less than 1 out of every 3 people were screened and tested for HIV in the past year. So the problem could actually be much worse than what we're reporting. Next slide. So why do STIs increase the risk of HIV? Well, you got to think about the skin as a barrier. The skin is like a coat of armor. It protects the body from infection. But if there's a break in the skin, then germs can get inside. So as you saw with syphilis, you saw that sore, you saw that ulcer. So that is a break in the armor of the skin. So infections like syphilis, infections like herpes, which we can talk about next time if you like, make it easier for germs like HIV to get inside the mucosal parts of the body. So the mouth, the vagina, the rectum, and get into the bloodstream and cause infection. Next slide. So when I started 40 years ago, I went to a lot of funerals because there wasn't really good treatment for HIV. Then we started getting better treatment, but people had to take 10, 15 pills, 2 or 3 times a day. Fortunately now, for most people, they only have to take 1 pill once a day. And we know that if they do that, that can dramatically reduce the amount of virus in their body. So not only can they be healthy, but they will not be able to transmit or give the infection to other people because the virus is under control. Next slide. In addition to pills, we know that some people who can't take a pill or who have trouble swallowing a pill, or they forget, or they're concerned that a family member, if they see these pills, might wonder what's going on. So we have a new type of medicine that people can get, and that's an injection. They only need to get this injection every 2 months, and that will control their HIV virus so they can live longer and healthy lives. And we'll talk about a similar medication that can be used to prevent HIV the next time we talk. Next slide. So with treatment, HIV can be controlled. People can live long and healthy lives. They can live, to their 70s or 80s or longer. They're more at risk for getting, cancer or heart disease or anything else that people can get. So they won't necessarily die from HIV if they get it under control. And again, if they're under control, they won't be able to spread it to other people, to their sexual partners or to their infants. Next slide.
Dr. Goldhall, we're at 15 minutes to the hour.
Okay.
Just a heads up.
Yep. And without treatment, as we said before, it can be serious complications. So just in summary, STIs are common. They can travel together, as we saw with our first case. They may not have any symptoms, as you all correctly pointed out. The complications can be devastating. It may make it easier to acquire HIV. We didn't get a chance to talk about the mental health, the psychological implications, but that can be serious. But if we can get people in, we can get them treated, we can get them managed, and most importantly, we can prevent these infections. So I'm going to hold on questions. We definitely think that you all can make a difference, as we talked about before, by getting people educated and linked to care. So we'll answer questions at the end after Dr. Amisty's presentation. We can just skip that.
Okay. Okay. Oh, I'm not muted, right? So, okay, so I'm going to continue. Thank you again. I had the chance to say that. So I'm going to talk a little bit more about other sides of STIs and HIV that they're a little bit more difficult sometimes to assess, but I think equally important. So what are the factors that contribute to STIs and HIV? What are the risks? For example, if you live far away from an urban service center because you don't have like clinics close, that will be a high risk because you may have an infection and not being able to get treatment for or have access to healthcare. If there's your educational level is not high, sometimes it's harder for us to know about STIs if we do not, if we can read well, if we don't have information that that can reach us because we don't have that educational level that we need to be able to read or to comprehend the information. If we are seasonal labor force, seasonal labor and migration, because we come to work and we work. We don't have time for anything. And so our focus is mainly on that. As you know, we spend many hours working and then very little time or opportunity to really go and get checked out. The accommodations and working conditions are, of course, factors for all of that. Crowded living and poverty, because that actually affects how you may be feeling some things, but maybe trying to hide what you're feeling and not really able to discuss it with your with the people at the quarters where you're living. Poverty has all kinds of effects because you may not have money for transportation or to go and get checked out. Hard working conditions, limited access to health. We've talked about that. Limited access to education. And of course, one important factor that is not talked about so much, but there are people doing a lot of research on that, is the migration travel. It's during the migration travel and post-travel, a lot of people suffer from food insecurity, violence during the travel, infectious diseases, because they get diseases that are not, probably so common here in the US. Sometimes people have a hard time diagnosing those. So all those have an impact later on when you are in the US and can cause more severe consequences if we are in that situation. So in summary, like hazardous the living conditions really have a lot to do with our health, not just physically, but also mentally. And that we're going to talk a little bit more about that. If you have a risky job, if you have mental health issues because you're here and you're alone and you get sad, and people sometimes get ideas that they don't want to live anymore. Like if people, for example, also start using substances, because that affects, that kind of makes you forget. I mean, a lot of people that I see is like, oh, you drink a lot of alcohol. It's like, yeah, I just don't want to think very much about my situation or my family or what's happening. So our own situation, their own situation where the workers are, really makes them high risk for having some, real difficulties with mental health, and then finding solutions in sometimes in alcohol, even sometimes in drugs. So as Dr. Coho said, and I want to reaffirm that, is most of the STIs are asymptomatic, and you knew that. Like a lot of the STIs do not give you any type of symptoms. And so, but that I wanted to say that about that, it does require a high level of knowledge on the part of the migrant worker to really know, oh, maybe it's possible that I have an STI. So even if you don't have symptoms, if you had a little bit of knowledge, at least you know that, there may be something going on because of what I did, or because of what happened last night, or because of what happened last week. So, we don't have to wait for people to have symptoms, because that's not going to happen a lot of times. And some of the risk factors that, that I mentioned, I want to add that if you have been working, if somebody has been working as a farm worker for a long time, that is also a factor in having STIs, very indirectly. Why? All of the things that I've been mentioning. I mean, you are working so hard, like, I don't know how many hours a day for many days a week. You don't have a lot of family around, you don't have friends, all you do is work, work, work. That affects your mental health and affects really your state of mind, in the way, like, you get really sad. You can start, going out with your friends and having some drinks, and we will talk a little bit more about that, but this is why, that has been said in the studies, that if you are working as a migrant worker longer, then you're more at risk. There's also, like, going along with that, of course, if you have knowledge about STIs, what are the things that have to do with people having more knowledge? I mean, if people are younger, they probably have more knowledge of STIs. This is just what's reported. I mean, and I think it's because a lot of the kids nowadays get a lot of the information in the school. But educational status, as I say, is important, because educational status helps you have access to the information that is out there. If you reside in a city, having worked as an agricultural worker for a long time, again, I mentioned why that's also a factor that that really impacts on whether you've heard of STIs or not. I do see a lot of patients that come sometimes from upstate New York for the farms, and they don't have any knowledge of STIs or what they are, and then so we have to do some work on that. So in terms of the education, the educational status, some of the studies, because I'm like really here looking at what other people have done all over the world and here in the US in terms of farm workers. One of the things that's very striking is that women are really at a disadvantage in comparison to men, and kind of the knowledge that they have about STIs. Women have much less knowledge. For example, in this study that was done by some researchers, it was like maybe a quarter of women knew that they have heard about sexually transmitted infections, compared to almost 60%, more than half of the men. So even if there was knowledge that was reported, still that little bit of a few women, like with the quarter women and the more than half men that had some knowledge, did not have sufficient knowledge. So it's not even like this a percent of people have like good knowledge. They do have some knowledge, but even the knowledge then is not good. So it's a really difficult situation, and that contributes a lot to the STIs. The other studies, like for example, looking at what STIs people know more about, the one that a lot of people heard about is HIV/AIDS, but less than 1/4 of women have heard about HIV/AIDS, which is like, you find that unbelievable, but it's true. 8.5% of the women, less than 10% or less than 1 in 10 have heard of hepatitis B. Men, on the other hand, almost half of them have heard about HIV/AIDS, and that's still really low. And 20% of them have heard about hepatitis B. So, so a lot of like, if you keep asking, the rate of those who stated that the sexually transmitted infections or STIs are only transmitted through sexual intercourse was 26% for women. Like 1/4 of women knew that the STIs are only transmitted through sexual intercourse, and less than half of the men knew that. We hear that all the time. Did I get it from the toilet? Is it possible that something else happened? Is the water? That was the other common thing. Oh, that was the water. That's not, it's like STIs are only transmitted through sexual intercourse. We said something before about younger adults, adolescents having more knowledge about STIs. And that is something that has been reported in the study. But what's interesting is also at the same time, the younger individuals are the ones that get more STIs compared to other age groups. So they do have more knowledge, but they get more STIs. So sometimes knowledge is important, but knowledge is not everything. There's many other factors there. So in terms of how you protect yourself, and like in going back to looking at women's knowledge versus men's knowledge, so women who do not know anything about any protection methods against sexually transmitted diseases, we're not talking about family planning, we're just talking about STIs. It was 3/4 of women, more than 3/4 of women did not know about protection methods. And maybe half of the men knew about it. These numbers are dismal. This is very low, especially among women. So of course that is a risk factor for getting STIs and even HIV, and linking that to some of the risk factors that we look at in the literature for migrant workers, include engaging in unprotected sex, because we're seeing up there that a lot of them do not know about protection methods, consuming alcohol and drugs during sexual activity, which we have talked a little bit about, and we're going to talk a little bit more about that, and having limited access to medical facilities, all things that we've been talking about. So I want to mention, because we have some subpopulations that are probably at even higher risk than when you talk about men or women, is the the LGBTQ population, who says a gay, lesbian, bisexual population. They are much more at risk for having acquiring STIs, not so much because they are doing riskier things, but because they have less information, and because a lot of the times they have less access. Not because they can go to a place, but sometimes they feel like they're going to be discriminated against. They feel like they can't disclose their status to other people, especially in our communities, that sometimes is a little bit difficult. So we have to take that into account. And so in part, because that's the work we do, we have to be able to discuss sexual health with all the populations that we're working with. And we can never assume that people are just having sex with the other sex. I mean, there's people who are having sex with same sex. And this is very important to also have in the back of the mind. And you know, we look at other immigrants in other countries because we are interested in seeing whether the situation is similar here or there. And I think it's very similar. So in Peru, for example, there's a big Venezuelan immigration influx, and most people who've been married or had health insurance and have been residing longer in the country were more likely to have access to healthcare for HIV and STI. And of course, that makes a lot of sense. Physical and mental disability were associated with lower probability for STI testing in females. And I think that this is something that I have been trying to mention to you. It's not just having the access and having the clinic next door, but is having, you know, also the kind of confidence that you can go to that clinic and you're going to be attended, and also even realizing that you need to do that, because when people are, for example, depressed and other things are in the head, you know, like when you have like trauma because of multiple issues that maybe, you know, may have happened in your life, you're not going to be thinking about, you know, the first thing is going to be, oh, I need to go to the clinic and check for STIs. There are competing needs in your head, and there are things that you really need to get done and really are bothering you that take priority over those kinds of things. So we have to really be aware of that too. Along the same line, yeah,
We're at 2 p.m.
Okay. Yes.
Yes, we're at the hour.
Yeah. Okay. We'll try to go fast. Are we gonna have time for the breakout rooms? I think it's gonna be really tight.
We could do the.
We can go directly to the breakout rooms. I wanted to mention alcohol, but I think I have talked about this a lot.
Or Sylvia, do you want to just do one case and then we'll just by yourself, and then we'll do the others when we do the second webinar?
Yeah, or we can do the 4 cases if we have like, I don't know. What do you say, Vanessa?
I think Dr. Kohal's suggestion is good. Maybe just do one here and lead the entire group. We're a relatively small group.
Okay.
So I think that makes sense. And then revisiting them next time would be a good idea.
Okay. So let me, I'm going to skip a lot of the things that I wanted to talk about. But one of the questions that I wanted to ask you was if you feel comfortable talking about sex with your clients, regardless of where they are. And I'm going to leave that question there. So that is something that we can start talking about in the next webinar. We're probably going to open with this question because I think we both, Dr. Kohal and I, think that this is a very important point. If you don't feel comfortable talking about sex, and it's possible that you wouldn't, because a lot of physicians don't even feel comfortable about talking about sex with patients. So we need to address that. But I throw the question out there so you can start thinking about that, okay? So I'm going to be talking about the scenarios. We're not going to do a breakout room, but I'm going to talk about this one case that Dr. Kohal started talking about. And we all remember Ramon, right? Ramon was the guy that had chlamydia and gonorrhea and was treated, right? We all remember that. Okay, so I'm going to tell you a little bit more about Ramon. I'm going to tell you a little bit about what happened to Ramon and how he came to the US, because I think that's what I'm trying to say. The story around the person is really important. So Ramon came to the US. I was working in a farm in upstate New York. His family was back in his country and he needed to leave them to come to the US and earn money. He came by himself, he was lonely, and he didn't have many friends. So he started drinking more, met other coworkers who would drink after work, and sometimes they used other drugs when they were drinking. A couple of times he passed out and he had no memory of what happened to him. Ramon did not have a lot of information about STIs and did not even think about the need for protection and condom use when having sex. he sometimes paid women for sex. So the questions that, this is in Spanish. The question that I have for you is, what do you think the factors that we talked about just briefly before, how do you think these factors are related to Ramon's STI acquisition? Then the second question, what are the challenges in Ramon's case in identifying and helping him gain access to testing and treatment? And when he gets access, what can we do for prevention? So we're going to open it up for people to start talking about what you guys think.
And do you want folks to just talk or put it into the chat or both?
Yeah, no, you can talk. I mean, I think that that's what we said.
Yep.
Please, Vanessa, correct me if I'm wrong.
Yeah, so unmute yourselves and jump in there. What factors were related to him getting an STI in the first place? What are the challenges in getting him treatment? And what could we do to prevent him from getting infected again? And think about the Ramones that you work with in your communities.
Mm-hmm. Yeah, it's just think about Ramon and Ramon's life. Ramon came here, Ramon was by himself, he was getting depressed, he started drinking more because of that. Then he was drinking and having sex. A lot of times he didn't remember things. What happens when people drink and have sex? I'm usually, what's your concern?
I can speak. I feel like you're not conscious about your choices, when being under the influence.
Right, exactly. So that leads you not to use condoms or protect yourself, right? Or even, like think about, oh, should I be having sex with this person, right? So what else? What else is a factor there in Ramon's life?
It was mentioned that he was paying women for sex, so maybe he didn't have a clear understanding of his partner's history and having that conversation with them.
Exactly. Yes, that's a huge factor when people pay for sex, and like they it's a really big factor because that person who they're paying for sex is probably also getting paid from other people, like we don't know that, but it's risky, right? What else? What about him being depressed, sad, alone, without family? How is that a factor? Yeah, exactly. So, Julio, but say more about that. Un poquito más sobre eso. So Julio says the factors are being an immigrant and being alone in the USA. So yes, I agree. So but how does that work? Can you say more about that? I mean, a lot of the times it's like being alone is what actually drives these behaviors, about going out with friends, starting drinking because you want to forget, and also paying for sex is something that people perhaps do because they feel alone and they think that that's what they need. So being alone, being a migrant, not being aware of the culture, those are also factors for that. So let's go right to the last question. Then how can we prevent a future STI for Ramon? What would you do? Any of us can do that. What would you do?
I'm sorry, could you repeat the question, please?
So how would you help Ramon to further prevent other sexually transmitted infections? Like he got a chlamydia and gonorrhea already. What would you do after you treat him to try to help him so he doesn't get other STIs? Having told you all the factors that are also, impacting on that, what would you do with Ramon?
Educate him.
Yes, absolutely.
Tell him about safety sex, and like before getting involved with someone, like trying to like see if they're past, see if they have some kind of STIs.
Right, right. What about if he tells you he's really sad? What would you do? Refer to behavioral health and substance abuse services, right? That's perfect. That's fine. What else can you do? What if you don't have any, place to refer him right away? Can you talk to them? Can you, kind of find out more what the situation is?
Yeah, you can screen certain behavioral, see if there's anything that you can assist in that moment. I think it's important just to talk to the clients, and then just listen to them and, focus on their concerns.
Yeah, absolutely. Exactly. So all that I think in summary is what we want to say is that, yeah, it's very important for us to know our patients, our clients. It's very important for us to talk to them and to really kind of explore, not just, like prevention of disease itself, but also all the factors that are surrounding somebody's life that are maybe making that person more at risk for acquiring STIs or HIV. Okay, so because we are really running out of time and I don't want to take any more of your time, I have to skip a lot of the things here. We're going to have maybe 3 minutes of questions. Maybe we can take 2 questions. And I'm going to tell you a little bit about what we're going to be doing in the next webinar, along with some of the topics that you will tell us about when you complete the survey that we recommended at the beginning. So do you are there any questions from anybody? And then you can either put them in the chat or you can also unmute yourself and tell us.
So the question is, if a baby is born with an STI,
Right.
will the baby be able to live a healthy life? It really depends on the STI and what kind of treatment is available. And a lot depends on when the mother gets into prenatal care and the quality of the prenatal care that she's given. So ideally, we'd like a mother to get into prenatal care in the first trimester, in the first 3 months after learning that she's pregnant, so she can get, proper nutrition advice and vitamins, and her blood pressure and her blood sugar can be checked, and so on. And she can be screened for chlamydia, gonorrhea, syphilis, trichomonas, hepatitis, all these things, HIV. And if any of those things are detected, if they're found, then we can treat her. And by treating her, we help her have a safe and healthy pregnancy. The problem is that some women, again, as Dr. Amnesty was mentioning, are coming from other countries. They may have a difficult passage into this country. They may be concerned about legal and immigration concerns. So they may not have prenatal care or may get into prenatal care very late. Then it's very difficult to find out about the problems and to get the treatment in time. So if we don't get the treatment until after the baby's born, we're really playing catch up. And that's when, we see a lot of the problems. So that's why it's so important for you all to spread the word, educate both men and women that, hey, if they're involved with a pregnancy, get checked out as quickly as possible, get checked out by good places where they get the appropriate test, and then follow through with the treatment recommendations. If that happens, yeah, then they can have healthy children.
Yeah, and remember what some of the slides that we saw is like how women